would like to take this time to introduce our panelists. Myself, I'm Kelly Dollinger, President of North Dakota EMS Association, and I'll be facilitating this town hall tonight. With us, I'm just going to pull them off the screen as I'm looking for them. First one I see is Jenny Moeller. She is a supervisor at State Radio. The next one is Miranda Jangula. She also is a supervisor at State Radio, and she'll be popping in and out as she needs to. With us also, we have Christopher Price from Department of Emergency Health Services, and Dan Schaefer from Metro Area Ambulance. Sorry about the motorcycle going by. Tim Blasl from a hospital association. Janet Wentz, who also is a supervisor for State Radio. We have with us Dr. Jeff Sather, State Medical Director. And Cheryl Flick, who is our State Vice President in the North Dakota EMS Association. And we also have the Director of State Radio, Dan Donlin, with us. So, how this is going to work, I already have 20 submitted questions that I've printed out. We will go through those questions. I know questions are going to be submitted throughout the evening. We have it to where as those questions get submitted, they'll get fed to me. I will read the questions and then direct to the panelists to answer those questions. So I don't think we need to get into anything else beyond that, so we'll just get started. And this first question is going to go to Dr. Sather. Dr. Sather, this question is, our service has heard through the grapevine that if we leave the rig following a run for 3 hours, the contagious droplets will be gone. Is this recommended versus cleaning and disinfecting everything right after the run?
Remember, take my mute off. Okay, that's a good question because there is a part of that comment is true, but I need to put it in context. The 3-hour comment has to do with how long the virus can remain airborne. It has nothing to do with how long the virus is viable on surfaces. So the 3-hour comment has to do with droplets. If something's aerosolized in the air, that could be floating in the air for up to 3 hours. And what does that mean for cleaning of EMS? And if you look at in a building, for example, in our health system, in our clinics where we have suspicious people that come into a room, our cleaning process includes leaving the room alone for 3 hours and having a cleaning crew come in and deep clean the area. Now, that's in a room in a building, and obviously EMS is going to leave their rig and sit for 3 hours and then come back and clean it. You might need that rig. You don't have enough to put aside. When you stop and think in North Dakota, rarely there's not a little bit of a breeze. So when a vehicle's sitting outside and you open doors, you got some air circulation through a vehicle that you don't have in a building. So those droplets suspended in the air are going to tend to be washed out with air movement more quickly there than they would in a normal room. So that 3-hour thing really has to do with airborne virus. And so it has nothing to do with the surface. And so regardless of letting it sit 3 hours, you still need to clean the surfaces. And depending, I don't think we really know for sure. There's multiple studies out there. You can find different information if you will look for it. This virus is known from what we know now, and depending on the surface, can last varying times, and up to 3 days on the surface. And so unless you're going to set a rig aside and not drive it for 3 days, you need to go in and clean and disinfect the entire rig. So that includes wiping everything down and disinfecting it. And really, truly, cleaning processes we should be doing regardless, because that's true for any virus that infects influenza as well. So that's the short answer on that question, I think.
Okay, very good. And since we're talking about that, this next question would go right into that. And this one is also for you, Dr. Sather. How long should a disinfectant be left wet on a surface before wiping it down?
So it's regardless of the type of disinfectant, there's cleaning, there's sanitizing, disinfecting, and there's sterilizing. And so cleaning of a rig, and just like washing your hands, soap and water is good as almost anything to get off the surfaces. But we wipe down, most of us might have pre-made wipes of some type that we use. Some of us might have some disinfectant sprays. If you're wiping it down, really the sanitizing and disinfecting time is letting that disinfectant dry on the surface. So we want to wipe it down, spray it down, and then let the disinfectant dry. So it's the drying of that disinfectant that actually gets rid of the virus or deactivates the virus.
Okay, thank you, Dr. Sather. Our next question is going to be a dispatch question, and we'll let this go to Jenny. Have you started to receive location information of positive COVID cases? If so, can you explain how you receive it, distribute it to other PSAPs, and is it immediately available for dispatch, or is there another process it has to go through first? Sounds like she's having some microphone issues, so I'll just kick it over to Janet Wentz. Janet, can you answer that?
Jen, go ahead, Dan.
Yeah, I can jump in on that one, Kelly, until Jenny gets her microphone fixed. I think she planned that, but I'm not sure. No. So what happens, to my knowledge, Jenny is the one that deals with the release of this reception and release of this information directly from the Department of Health. So the Department of Health sends her confidential, password protected document, a spreadsheet that's got the address locations, and then it gets separated out by county. And then Jenny takes that information, and by the county, she determines which PSAP or 911 dispatch center. And for those that don't know, there's approximately 21, 22 dispatch centers or PSAPs across the state. State radio is one of those. So she separates this into the addresses by county and then sends those applicable county addresses to the specific PSAP that is responsible for dispatching first responders to that address. Now, for the most part, that would be one PSAP, but there are times, from my understanding, when it might involve two PSAPs, because there could be one PSAP that sends fire or EMS and another one that sends law enforcement. So that information is to basically go to the minimum eyes as possible, minimum number of people. So it usually gets sent to one or maybe a backup, 2 people at the PSAP. Then that PSAP is responsible for how that address information gets entered into their CAD system, if they have that. And then the only time that address would pop up is if there's a call for service at that address. It's not like it's going to be searchable. I'm sure you could go in and do it, but it's when it's an address 911 call comes in, or a response, a law enforcement response for like a runaway report, and they put the address into CAD. If it's on that list, it will pop up. Secondly, daily is how she receives this information, is daily. And every day now there could be additions of addresses, or there could be reductions. In other words, addresses that need to be removed as well. Once the Department of Health determines the subject or subjects at that location are no longer contagious, infected, on that quarantine time, then that information is that address needs to be released. Now we have assisted living centers throughout the state, so a dispatch center could have the same address in there multiple times, but when the release then comes out for one time for an address to be removed, well, they remove one address, but there still could be 5 still there. So we're aware that that location has that. Jenny, is your mic on yet?
I have it on. I haven't muted it yet.
Okay, go ahead and cover what I missed.
You didn't cover, I mean, you didn't miss much. For the most part, just so you guys know, the list comes out usually between 8 and 10 in the morning. Sometimes they're going till noon, depends on the Department of Health. So we try to get that list out before the afternoon so that it's current. Just so you guys know, the list is from basically the day before. We don't have it of that day, so I get a lot of phone calls. Hey, I know that I have a positive case today. How come it's not on the list? It's basically from the day before is where they're taking the information and providing it to me at midnight or 1 o'clock. They get the list. So then the next day that address will be on the list. So every once in a while we might get an address here and there that should be on the list right away in the morning, but isn't going to be on the list till the next.
Okay, thank you. This next question came in specifically a question for dispatch. So Jenny, if you want to stay unmuted, this is for you. You can try to explain this. Can you please explain universal precautions to responders? That could mean either a confirmed case at the location, suspected positive case, or a possible close contact case, correct?
Kelly, we'll
It
have
could be any of those three. Go ahead,
yeah.
Dan.
Yeah, we could have Janet respond to that, if
Okay.
that's all right. Universal precautions and how that's put out.
So when in our CAD system, when we receive a call and it comes up that there's close contact or a positive case at a location, we are advising our responders that we give the basics of the call, the chief complaint, the situation, the address, and we say universal precautions. There was a question as far as explaining what the universal precautions are. We cannot give that medical history information over the radio. If we say universal precautions, we really need to have the crew call us on the phone and ask what that is, because we can't release that medical history information over the radio, whether it's HIV, whether it's the positive COVID case or close contact.
Okay, thank you. Our next question is going to be for Chris Price. Chris, can you explain the procedure for updating the big picture information and how much time is devoted by staff on a daily basis to do the updates? Are squads responding to your daily request to update their information? Would you please consider sending an email to services explaining how to update the information for their squads?
All right. Well, first of all, thanks, Kelly, for hosting this and giving us the opportunity to have a chat with and answer questions. And I didn't have a chance earlier when you introduced everyone to introduce Carrie Crickabah and Sam Harrison from my staff. So just let everyone know they're on, and probably may end up answering these questions better than I can. First of all, I'll admit I am not the big picture expert, but I do know that the squad leaders have always had access to big picture to update the roster and vehicle information. And as far as like the other information that the staff has to update and the frequency of that, we do that as needed. And oftentimes while we're on the phone with somebody who's asking for a change to be made. So, given that the current situation, some of that may not be happening as quickly as in the past, but I think now that we have some additional staffing from outside organizations here at our office, we're able to devote more of the staff time, at least the administrative staff time, to EMS issues. As far as information on providing, I guess, a cheat sheet or something like that on how to access the big picture, we sent that out along with our update on March 27th. So we post all our updates on our website, so if somebody wants to refer back to that, they can find it on the March 27th update. And I'm just making sure I'm covering all the questions. And I think in general, when we first started doing updates, we realized that the limitations of our list, we did reach out to all the ambulance services and quick response services and try to get as much accurate information as we could, and so that we could have like a baseline as we send out information during this event. So I think I covered all the questions there, but I'll be happy to catch up if I didn't.
And I know early on too, Chris, that because of big picture not being updated, we have taken your daily updates from the department, and we've been posting them on our website since the beginning of this. And so every one of them has been on our website too for the members to look at. Okay, you may as well stay on the unmute here, Chris, because this next one's for you again. Can you please explain the process for ambulance services to get reimbursed for COVID-related supplies? Our emergency manager is a great resource for us as far as providing information about registering with FEMA and keeping receipts to submit. And Neil Frame has emailed services contracted with Metro Billing about CARES Act funding, but I'm not sure if all squads know about this.
Yeah, I think the way that I would approach this is referring back to the emergency manager. They are a great resource, and they're tied into DES, which, because this is a declared emergency, DES would be the entity to manage the FEMA reimbursements. On another note, we do have contracts with 100 ambulance services that if we utilize them, then there will be reimbursement through that also, that mechanism. So admittedly, I'm not the expert, and I'd be happy for anybody else to jump in who might have a little more information about the reimbursements during emergencies. And I thought maybe Tim Wiedrich would jump in, but I guess he wasn't able to. But I would say your first stop would be the emergency manager in your county.
And save receipts.
Yeah, and save every receipt and note every COVID-related expense.
Very good, thank you. Dr. Sather, can you please explain your role as state medical director and how this role may be different than our local medical director? Do your instructions to services on a statewide level during this pandemic take precedence over local medical director protocols?
All right, let me try and go through a high level of that, and then if I miss something, Chris, I'll let you jump in. But as all ambulance services have a individual medical director, that's the way we operate in the state, and ambulance services operate under the medical direction and the authority of their medical director, and it's that individual medical director that finalizes protocols, is the one that adds new protocols as needed, and should be given medical direction to that ambulance service. The position of the state medical director in our system is serve as a medical director for the department within the section of the Department of Health, and that role is to specifically give medical input into issues going on at the state level and to policy, into some of those issues. Into development of recommended protocols for the state. And when we develop protocols, for example, at the state level, they're recommended. The medical director of individual services needs to go through those, can modify, and then has to finalize the authority for that. The only way it would be different during a pandemic, and I saw Tim come in too, and he can correct me if I'm wrong, if you take an issue like DAPL, where we pulled many ambulance services into a state-run organization, we had specific protocols that were then developed. So I functioned as a medical director for that specific incident. So that was outside individual medical directors, because we were working as a unified service, so even though we had many ambulance services pulled into that. With this pandemic, we have not gone to that level where we have direction coming down like that on individual ambulance services. So that part of the question is, no, your individual medical director is still the one you need to be going to for your protocols and the direction is what should be followed. Anything to add to that, Tim or Chris? Did I cover it appropriately?
No, that sounded great to me. And Tim has since joined us, and I'd asked him to backtrack to the previous question about the FEMA reimbursement.
So this isn't going to be much of an answer, but it's the best I have. You know, we've never been down this path before, and so Chris's answer was correct in terms of save your receipts. we don't know what all is coming from federal reimbursement and what will and what won't ultimately be eligible. So what I would suggest as your first reliance is on the memorandums of agreement that we have in place with every ambulance service that details how during a large-scale emergency your reimbursement occurs. And that, just to remind you, requires you to first of all attempt to bill the patient if in fact the patient has insurance and it can be billed and you're successful with that. And then the contract covers what is not reimbursed by insurance. But having said that, that's our normal position. We don't know exactly what will be coming from all the ins and outs of the various federal programs that are coming that may or may not reimburse ambulance services outside of the agreement that we have with you. And one quick thing just about that, to make sure that if you are expecting reimbursement under the agreement, that the Emergency Operations Center, the State Emergency Operations Center, and the DOC is an agency of that, the Department Operations Center, is the one that has specifically assigned you to a mission. If you self-deploy, even though it may be great work, it will not be reimbursable under the approach. And I know we had some situations with Apple where there was misunderstanding of that, where services began to do their own deployments and then we're expecting reimbursement at the end of it. It doesn't work that way. You have to have a specific mission assignment from the emergency operations system.
Okay, thank you. And because Tim did just pop in, I didn't get a chance to introduce him in the beginning. Everybody, this is Tim Wiedrich, Section Chief of Department of Emergency Health Services, right?
A change, Chris, or Kelly, I'm not expecting you to keep up with that. And so it's now the section of health resources and response. So it's been expanded to include the licensure of hospitals, long-term care, and then also EMS and the other emergency preparedness functions that were previously a separate section. So it's a larger section, but still the same responsibilities in terms of the EMS activity, just added some more onto it.
Okay, well, I stand corrected then, but I gave it a shot.
It just rolls off the tongue.
Right. So our next question is going to be directed to Dan Schaefer from Metro Area Ambulance. Dan, they say, thank you for doing the training videos and sharing them on Facebook. They've been very well received and much appreciated. We love to see them continue every month on a different topic that small squads like ours could use at a monthly meeting. We may not have the call volume as the big services, but our goal is to provide the best patient care we can is universal. Would you be willing to continue those?
I have to answer that right away. Okay. So the long story short answer is going to be this. You know, if I believe strongly that we need to work together, you know, with the association to put out those videos, and I'm more than happy to work with the association to do that. And but again, you know, we all have our jobs to do in our positions, and so the big question is if there's help, and we're more than happy to do that as a company. And but I'd like to kind of circle back to a couple things that we might as well educate while we're here. Going back to one of the questions was about the money that was received from the federal government. Every ambulance service in the state did in fact receive a stipend that came in from CMS, the Medicare, which was based on your call volume and the things that you, and again, how many times you bill Medicare, et cetera, et cetera. Those funds are available for you to use in the interim to get you by. Now, we know that a lot of ambulance service volumes have gone down, and they may be expected to do some things that they're not reimbursed for. And that's where that money can potentially go. And as long as you're not buying beer with that money, I think you're going to find kept receipts and the things that you need for your ambulance service to keep operating. That's what that money is for. Will you have to pay it back? Only if you spend it inappropriately. And again, that goes back to an earlier point that was made about keeping your receipts. And so, again, that was kind of some of the help that came from the federal government at this point. And that was the Neil Frame had sent that portion of it out. Best cares, you know, I think that you know, in this time, and everyone is quite concerned about, you know, what is the best care, and you know, it's kind of a challenging thing, and everybody has a medical director, and I think it's extremely important at this time that you reach out to your medical director and discuss your standard of care, your best practice that you're going to do for your area. There are areas that aren't even touching any COVID, and there's areas that are smack dab in the middle of a whole lot of it. And so some of those practices could vary, but ultimately you've got to protect yourself. And the questions earlier about disinfecting and doing those things, that is an extremely important part of trying to keep you as providers safe. And that ultimately is why I was trying to put out those videos, why we as a company were trying to do that. And we discussed it here. We don't want anybody going out for 14 days, much less getting sick. So yes, the idea of keeping those videos going, we're happy to do that as a company. But we want to work very closely with the association and the health department to make that a unified message and universal, as was mentioned earlier. Man, that was a long answer. Thanks.
All right, thank you, Dan. And actually, you actually clarified the follow-up question quite well, so we don't even need to do that. I will pull a question off the chat board because it directly relates to the videos that you've done, Dan. A couple of them. One is, where do we find the videos that Dan has done? And the answer for that is you find them on Metro Area Ambulance Facebook page is where you can find the links to those. Unless, Dan, have you guys uploaded them to YouTube at all?
I do believe they are on YouTube. I have not gone and looked at them, but they are, I believe they are out there, yes.
Very good. So there's the answer, Metro Area Ambulance Facebook page, and you can also search on YouTube for those. Okay, the next question would be for for Chris and or Tim, since he's sitting here. I've received items from the cache. How do I go about replacing them? And can I share the cache items with neighboring agencies?
All right. So the short answer is the replacement doesn't occur until after the equipment is generally available on the private sector distribution chain. So said a different way, the cache is there as a safety net for when things aren't available in the private distribution chain. We're distributing. The normal process is that when it does become available, you're expected to replace it back in. And that's so that we have a safety net for the next time that we need the cache. And that's generally the way that works. Now, the same caveat that I put out before is going to apply here. If, in fact, we receive funding that replaces the cache, then that won't be necessary, but we won't know that at this point. There are some differences if you are a public safety entity that does not charge for its services, then you're not expected, if you can't replace the equipment. So a law enforcement agency, for example, might very well not be replacing what they've consumed. So that's the lay of the land as it is right now. We'll know more as some more of the federal money starts to flow. Excuse me. And we see what requirements are around the use of that federal money.
Okay, thank you, Tim. Dan Schaefer, you're back up again. Can you explain how you prepare a rig for service, and does everything need to be in a plastic bag in that rig? And also, what's the best way to disinfect trauma bags or any other type of first in bag type?
Oh, goodness, good questions. And I will tell you that I am not the expert on getting the rigs ready. I'm sitting behind this desk too much. But our protocol basically says that in the mornings when they come to work, they're going to do their normal rig check as always, and of course disinfect. So they're going to spray down the entire truck, and they're going to make sure that they start with a clean truck, even though. And at the end of the day, they end with a clean truck. But it's like anything else. You gotta follow up, right? We have seen better practices with our guys each person is keeping their PPE in a gallon Ziploc bag. And that's where it's kept during the day. Now, we also know that if you're going to use multiple N95s, the best thing to do is on a rotating basis, keep them in a brown bag and let them dry as you go along. But typically they can get by with a few, N95s that they're fit tested for in their equipment, and keep those clean in a plastic bag. The thing that was best suited as we were looking and following up on these things is to keep the least amount of product exposed in your ambulance. So why have laundry that's not covered, or why have anything that's not in a bag that's covered up that you can wipe off quickly with disinfectant? You never want to leave exposed linen, for example. You don't want to leave any bags that you're not going to use often exposed. So we have cabinets. We try to keep everything in a cabinet to the best of our ability. Now, our oxygen bag, our airway bag, obviously the same, and the med bags and that, we spray them down with the disinfectant and let them dry. Going back to the other parts of the truck, the rig itself, we try to disinfect top to bottom, from the front to the back. And post call, if you don't take too many bags out of the truck and use on the patient and expose the bags or anything to the patient, you're going to find yourself with a lot less cleaning post call. And so again, keeping things stored away, that's the better plan. We've got, our guys are getting very good at quickly getting the rig disinfected and ready to go. I don't know how clear I can be about that, but the long story is that try not to expose your equipment any more than you expose yourself. And I think you'll find yourself in a better place. These patients, if you're using the appropriate PPE, they're not going to be a big risk for you. You can stay in a very low risk area, provided you follow those best practices. And we've laid those best practices out, but I don't think tonight's the time for them because we've pushed that information out. But that's my best answer for you.
All right, thanks, Dan. The next couple of questions, they could really relate to just about anybody, specifically Dan, Schaefer, Chris Price, maybe even Dr. Sather. So I'm going to read, and there's two questions that specifically relate to ESO, so I'm just going to ask them both at the same time. First, how do I document verbal consent from a patient in ESO? And then I would like to know how we handle the paperwork on ESO for signatures when the ER staff now isn't signing any paperwork for us when we bring a patient in.
I've not heard of staff not signing. The not signing, I don't understand. So I don't know if we can clarify that question somehow, maybe when we open up mics later, because I actually, when I saw these questions today, I went down to our staff and asked one of the charge nurses if they're still signing paperwork for ambulance services, and the answer was yes. So I don't know if there's examples or there's different practices going on.
See, and personally, I don't see it not happening in the hospitals down here in Bismarck either. I'm wondering if this just isn't a misperception or a one-time isolated incident with someone else. I'm not sure.
It's not, Kelly. This is not atypical to have folks not wanting to touch paperwork and other pieces of equipment, etc. We're seeing that, and it is somewhat case by case, and we just aren't fighting about it. And so the best way to document, I'm not an ESO guy. We're Health EMS, EPCR, and what the answer still goes back to the old rules, and the old rules are pretty simple. If you can't get a signature, the absolute not going to happen signature, you document why you can't get that signature, and that's okay. Your patient was COVID, and that's the end of the story. Patient lost his arm in the baler. Whatever the case is, if there's a good reason, that same practice is long before COVID still applies now. We don't want to get into that habit of not signing and having the ER staff not sign, or doctors not sign for our stuff, but we can get by with that with a simple explanation. And that is critical. That explanation is critical when it comes to trying to run the billing process. And we know that with that documentation, we'll certainly be able to get that billing done. It's just more challenging. But it's just not worth fighting about at this point.
So really, it really boils down to, it's how you articulate the report and you document. And if you have a legitimate reason why you could not obtain the signature, it's just one of those things.
Yeah, yeah. You can't just throw down, well, patient was off the CT scanner. Well, what the hell were you doing? Get it done, you know. But when you have the other reasons and, you know, patient's family not there, there was nobody around, there was, you know, go back to the real reasons why you can't get a signature. First, get the signature. If you can't, family member wasn't willing, wasn't able, then it goes down the list of all the reasons why you potentially couldn't get that signature. So follow your old rules and I think you'll still be just fine.
Fair enough. So now we have, if a member that refuses to be fit tested on the N95, can I keep that person on as just a driver? And I think maybe
I'll take part of the answer for you, Kelly, and there's others that can probably weigh in, but I would first engage your medical director and make sure this person's educated about why they should be fit tested. You know, I guess it says that refuses to be fit tested, so if the person's actually refusing versus failing a fit test, probably two separate issues there, but if they're actually refusing, I would start with engaging your medical director and making sure the person's educated for the reasons. Then it becomes more of, I think, and maybe Dan can answer more, but then I would look at it more as now is it a liability issue for, because one of the requirements of OSHA is that we, healthcare providers at any level, provide protective equipment for our employees. And now you got an employee that's refusing to go through the steps, and then he became COVID positive, for example, is simply, you know, there's nobody that's simply a driver. They hop in and help out with other things unless you've got lots of help. So, and then you're also in a vehicle. If you're doing some aerosolizing things, that person's coughing a lot in an enclosed area, then I would worry too about the airborne virus for that person. And I don't know, Dan, you got more to say about that, but it seems there's some liability issue on the then at the business level that you want to talk about, and maybe think about even legal weighing in on that answer.
Yeah, I could a little. I think that there's two parts to that question that are challenging. And you're right. It could just very simply be someone that just can't get a good fit test. And then you have to kind of go back to the universal N95, which I believe the 3M 1875, I think is the number. That's kind of the generic one, that one all fits all, and you have to live with that. As an agency, as a squad leader, as a county, whatever you are, whatever ambulance service you are obligated to provide that PPE and to make sure that your staff can go out there and do the cares in an appropriate fashion and do it in a safe fashion. Now, refusal of the N95, while, you know, not judging anyone, I think that we need to really ask that question. And you're absolutely right. First and foremost, you go to your medical director and say, gosh, Bill just doesn't want to do this. It's a problem. Does Bill really want to be compliant? Why would he want to expose himself and family to this kind of thing? So there's your argument. But going back as a service, you are obligated to make sure that equipment is there. You can't force anybody to use it. You can't force them to use it appropriately. You can only ask them to leave your service. So, you know, you got to deal with that. You got to say, you know what, there's only so much you can do. And that's what I would do, is just do your best to educate, just like a refusal.
I'd also just keep in mind too, and it's more of a, to me, it's more of a, you got someone doesn't want to follow a policy, so are there other policies they're not following as well? But from the practical side, without being fit tested, there's still a degree of protection from an N95. In fact, the recommendations are, unless you're doing aerosolized, the plain old mask like this, the surgical mask. And while we're talking about masks, maybe it's a good time to throw in proper use of masks. And I don't know what services are doing individually, but I think most hospitals now, I know our hospital is, to be in the building, you got to be wearing a mask. And because there's asymptomatic people out there too. We could have someone on this call that's actually a virus carrier and shedding virus and not even have a symptom. So I guess, if you really, that's a critical person, I guess you got to decide what you're going to bite off for someone that's not following a policy of your service. But I'd worry about the risk and if they get positive and how that would shake out with the morale of the service if they weren't protected.
Thank you. And we just got another question online relating to this same thing, and I'm gonna go ahead and read and answer this one. What about members who can't be fit tested because of facial hair? I like not shaving, and I like having a beard, but I had to shave my beard off because my policy at work was you have to be able to be fit tested or you don't get to work. So that was the policy pushing the issue for me. However, I also don't want to bring anything home to my family. So it really was a no-brainer. If you're a beard wearer like I am, and you're going to be working around COVID-19 patients and you need to be fit tested and N95 mask because of COVID-19 or any other infectious diseases that require an N95 mask, do yourself a favor and shave. And once this all goes away, perhaps we can grow our beards back. I don't know what's going to happen where I work, but I'm hoping to. So I think that's the answer for that one. So we're just going to keep moving on. Dr. Sather, should I or shouldn't I be doing a nebulizer treatment in the back of the rig? Keep in mind, some of us have long transport times.
That's a really good question. I'm glad somebody asked it. So there's increased risk with any procedure that causes aerosolization and potentially nebulizer treatment. I don't know that we really know how much aerosolization that causes. It's an interesting question. I say it's interesting because it was a question that was being bounced around on medical director blogs online and a couple of listservs through ASEP that I belonged to way back at least 2 months ago. I think end of February, early March, even before we really had much going on in the state. And some of the guidance and opinions out there, I think are very similar. I know there's services in the country where the medical director has said, nope, we're not doing them anymore during this. We're going to use MDIs only. I guess, and again, you have to ask this question individually of your medical director, but I'll give you my opinion on this. And just like any medical thing, there's risk benefit. So if we perceive that there's some increased risk, we may not be jumping right to a nebulizer treatment for someone who is not really an extremist. We have people with mild asthma that we may end up picking up or have mild shortness of breath that we, in normal operations, might just go ahead and give a nebulizer treatment to. However, with this going on, we should probably be a little more cautious with this. And actually, that's the approach we've taken in the hospital. We are using meter dose inhalers as first line. But we've got to remember there are some patients that those don't work well for. For a young, healthy person that can move reasonable air, the MDIs, are really, for efficacy, are just as good as, in fact, some camps think probably even better than a nebulizer treatment. Not true for everybody, however. Someone that's got a lung disease, isn't moving good air, the nebulizer treatment, giving the same dose of medication over a period of time tends to be better. So I think it's an individual patient decision, and also I think it's an individual medical director guidance you should be asking for on this. There's some patients, in my opinion, that if they're an extremist, that we probably should give a neb treatment, but we got to remember if we're doing that. I know our policy in the hospital here, if we're giving a neb treatment, then people are using full PPE with N95. Otherwise, for suspected patients, we're just using regular surgical masks. And so you want to make sure you're protecting yourself, and that could then increase aerosolization in the rig, which is, as we said earlier on this call, can hang in the air for up to 3 hours. So it's going to be there for your entire transport, most likely. So I would, I know it's kind of dancing around the question. My opinion is we probably don't jump to them as quickly, but if a patient really needs them, we probably need to be doing them. Our next step, if we don't get them approved, is we're going to be needing to intubate that patient or doing something like that as well, which is also getting down in the airway and putting you at just as much risk as the med treatment. And so if we can head that off, we want to. But again, take that question on an individual service level to your individual medical directors to get final decision on how you want to do that.
Very good, thank you. We did have one question just pop into the chat room. I think is a really important question, and we're starting to get up against the clock here. So I wanted to ask this question of Tim Blasl. Tim, what are some of the challenges critical access hospitals are facing?
Well, I think, again, I'll kind of handle that in maybe two parts. Obviously, first is I think testing. I think, in terms of, and I visited with Mr. Wiedrich about this, I think right now, based on the guidelines right now, I feel like we have adequate testing in terms of supplies, but, I've also heard some comments from the governor about opening that up to somebody that has just a symptom. So that will be a challenge in the rural area if we go down that road. So I think that's something I need to be working on. I think the next biggest challenge is the financial challenge. Again, we early on made a decision as an association and as a group to no longer do non-essential surgeries. And so we are getting back in that game here slowly. And that's being reintroduced around the country. But, visiting with some of the smaller critical access hospitals around the state, some of the CARES Act dollars are starting to filter into the hospitals here. And, visiting with some of the smaller critical access hospitals, if those dollars did not flow in, they were going to struggle to meet payroll. So again, some of those dollars started filtering in a couple weeks ago. There could be another wave of dollars coming tomorrow. We're keeping an eye on that. So we did get, there was roughly one area of the CARES Act, which was really the Provider Relief Fund, provided a $30 billion infusion into the country here, like I said, 2-3 weeks ago. North Dakota got $91 million of that. And so I think with some other financial programs, with the Paycheck Protection Program, and along with Medicare's Advanced Payment Program, that is where if you apply for it, you can get 6 months worth of Medicare payments up front based on your historical numbers. The issue with that is the interest rate is high. And the longer this disease goes on, it's going to be more of a challenge to pay those back. So again, in the next round of stimulus dollars, that not so much the stuff that came out this week, but the stuff that's probably going to be coming out in late May, we're going to work on that program to see if we can get the interest rate lowered, or to see if we can get those to be grant dollars. So Kelly, to answer your question, I think right now, probably up until maybe about a week ago, it was financial issues, because, you cut electives out of the system. And again, that's, Dr. Sather knows this. I mean, it's no different in a PPS hospital as well. That's probably 50 to 70% of your revenue. So again, when you don't have that coming in and no cash flow and maybe no federal dollars, there's a couple decisions you have to make. You either think about starting to furlough employees and, pay cuts, and obviously, staff. So in terms of cuts. So again, I think right now, I don't think the PPS hospitals are exempt from any of this. But in terms of critical access hospitals, I would say eliminating non-essential surgeries. Now we're slowly getting back into that. There was not an executive order to eliminate that. I think it was the right decision that we did in the state to conserve on PPE and other supplies. But as we go forward here, with things maybe being reopened, whether it's, obviously here in the state or around the country, there's been a lot of attention about bringing electives back into the picture. And I think we're moving in that direction. So, but I think other than that, I know obviously testing, but again, it just depends on where we go with that. And then the financial piece. So I think those are the two big things. And again, I think, early on we were concerned about PPE, but this is a compliment to Tim and the crew at the Department of Health. They've done a good job with the state cash. And so I think we feel pretty comfortable with that as well. I mean, you can never have too much, but I think there's an adequate supply today as we speak. And I don't know, maybe Tim would correct me, but I think he feels the same way.
Very good. Thanks for that info, Tim. Moving on here, Dr. Sather. Are there symptoms other than fever, cough, shortness of breath that are being found to be common amongst COVID-19 patients that might help alert EMS providers to this disease?
Yeah, there is, and there's actually a group of in-state people who actually looked at 1,821 positive patients and looked at the documented symptoms they had, and then looked at the frequency of those symptoms. I'm going to go down those, and then I can tell you about a couple that I know have been added in that I actually have some personal experience here with some patients. But the most common symptom is fever, and in this study, UND study, 89% of these little over 1,800 patients had fever as a symptom. Next most common was cough, that was 66%. Next was fatigue at about 37%, and then shortness of breath, actually in a fewer percentage came in, and myalgia, and nausea, and vomiting, and headache. Now, those are some of the early symptoms identified, but we know that there are other symptoms that took into place that have been identified. One of those being loss of taste and smell. And actually, one of our physicians here that was COVID positive because of travel way back in the early part of this, one of the things that he lost was taste and smell. I know of another patient that the only symptom they had was loss of taste and smell. And then listen to some interesting reports out of places like New York where they've had high volumes, and some of the lessons learned there. They're seeing some patients who the only real symptom was anxiety, and then when they evaluated those patients, realized they were a little bit tachypnic, so their breathing was fast. And then when they stick the pulse ox on this patient, who's not even complaining of shortness of breath, they're finding oxygen saturation in the 70s. And patients like this tend to get very sick very fast. So there's a whole myriad of patients, and some of the experience out of places like New York is these patients have what seems to be very minimal symptomology, but yet they get very sick. And when they have things like X-ray or CAT scan of their lungs, they have pneumonia throughout from this virus. So I think, the big symptoms are like I said, fever and cough, but almost any even minor symptoms could really be a patient with COVID that is relatively sick. It's really hard to distinguish just based on symptomology the likelihood that they're positive. And I think the more we test, the more we'll see that. We're starting to get some reports from places where they're just doing testing. We're finding positive patients that have no symptoms. So really, we're in a position, and I know it would be nice to say, hey, if you have this, this, and this, high likelihood of COVID. We see every day in the ER, we're seeing patients that have significant shortness of breath and cough and fevers, and it's not COVID, but that's negative. And then we see other patients that drove up at a drive-up somewhere with some minor symptoms and they test positive. So really what we need to do at this point in time with the pandemic going on, consider every patient we encounter as potentially being positive, and everybody you meet in public is potentially being positive. It's really the only way that we're going to protect ourselves from this.
Very good, thank you. Also, Dr. Sather, could someone who has recovered from the disease or who tests positive to antibodies still be a carrier and spread the virus to others? And if there's someone out there with an open mic, can you please mute your mic?
So it would be nice to be able to answer that problem, but I think the real answer is I don't think we know at this point. A year from now, after multiple studies have been done, I think we'll know. I also know from personal experience with some of the patients we've had here, because we're retesting healthcare workers to go back to work. And so there are patients that have, I can give you an example of one of our physicians who had COVID and was without symptoms for 7 days. And at 7 days, the protocol then is to retest and have, if you have 2 negative tests after being symptom-free for 7 days, you can go back to work. And then on retesting, had a positive test. So waited a few days, and at 10 days, retested and had a negative test, and then had the second test done that was positive. And so some of the things that we don't know about the test, a lot of these tests that are out there, you know, the testing, you know, you think about how tests typically are developed. We have a lot of information. We don't have a lot of information on these tests because they're so new on sensitivity and specificity for the disease. So there's multiple thoughts, and I think we don't know for sure, but some of these patients could be shedding virus intermittently at low levels and then pick up. And the real question is that virus active where it would cause disease? I don't think we know that. So I think the answer to the question is we really don't know. If it follows the pattern of most viruses and most viral illnesses, you'll have people shed virus for a long time after the disease. But once they become symptom-free, the virus they shed tends to be inactive. We would expect it's going to be similar to some of the other respiratory viruses that are out there. But until we have good studies, there's no way to give a definite answer to that. And again, the best thing to do is just use the precautions, wear a mask, good hand hygiene, and kind of protect yourself with all patients.
Very good. That was a good question, and I appreciate the answer to that one. This next question is going to be directed to either Tim or Chris. Somebody from some service submitted a question regarding there was concern of not getting or a delay in getting direction from DEHS. And I thought maybe with that, could we just explain the process that you guys go through to disseminate the information to ambulance services throughout the state?
Sure, and you know, I was intrigued by this question because I thought we had actually been ahead of the curve on getting information out, and so I went back and I looked a little bit of a timeline of COVID, and you know, we know the first case was identified on December 31st, and then the first case in the United States was identified on January 21st. And then we activated our Department Operations Center on January 27th. And as time went on, as we developed, you know, capacity and capabilities in our Operations Center, we issued guidelines both to PSAPs and EMS agencies on February 26th. And there hadn't even been a COVID-19 death in the United States at that time. And then we didn't have our first positive case in North Dakota until March 11th. And at that point, that was the trigger that we began communicating daily with guidance information and links to the CDC and links to other information that may be of value, like some experiences of the first places that had COVID in Washington State. And then we, at that same time, that was also the trigger that we were able to bring in additional resources to our operations center. And we started to make calls individually to each service to assess, you know, what their needs were, where they stood as far as fit testing and the PPE and just in general, what sort of questions or concerns do they have? And in the course of that dialogue with the services, we had 55 that had specific questions that we were able to follow up on. And that was all before about the middle of March. And as this event has continued on, we have provided a daily outreach to every EMS agency and every person that we have in our email database. So we are distributing 5,000 daily emails. We also share that with the Fire Association, which then distributes it through their network, and the Association of Counties, which distributes to their network. So that's law enforcement, PSAPs, etc. So, I think we have been moving forward as far as providing guidance, and that's always based on best practice and generally following the CDC recommendations. And we've tried to be a daily outreach to agencies, and all through this, we continue to answer, and try to perform our normal duties, and that, we get questions every day about, certification and training and things like that. And, we now have a temporary certification process or licensure process and a temporary or a provisional licensure process. And that have been communicated, and we actually have 6, 7, 8 provisional folks. So, I think we've been as far ahead of this as we can be at this point. And so, I know we also, we have a good partner with the EMS Association. They've done outreach to their membership and have done weekend meetings and webinars. And so I think that we have, and of course, it's my opinion, that we've been ahead of the response to this, and have been working to keep everyone informed as to the best of our ability. But I'll pitch it on over to Tim to see if he wants to elaborate some too.
I think Chris did some research, and I didn't.
I had some help.
So thanks for the overview, and yeah, if there's specific gaps you're aware of, let us know, because we definitely want to address any gaps. And so I think with that, we'll continue to do the best that we can.
Well, I appreciate the detailed explanation, and I'm sure that person that asked that question got their question answered. So great. There was a second part of that question. Once we get to our surge, what is the action plan for the surge, and is it ready to go?
So I'll take a stab at this one, but fortunately, there's quite a team that's working on the plan, and includes many of your panelists. So I'll throw that out there if anyone wants to chime in and add any additional information. But we have approached this sort of in a step-by-step fashion, and one of the first things was as a state, we provided hotlines, and that was intended to help the public, make the best use of the resources that were available, or not use the resources. So, for instance, should they call an ambulance because they have the sniffles? Well, hopefully they had that question answered through a hotline. But we knew that as time went on, there may be an opportunity where the EMS system becomes stressed. So the next part of that was that guidance we provided and an algorithm on how you can work with a patient that you believe may or may not have COVID, but doesn't have enough signs and symptoms that would merit a transport to the hospital. So we're trying to preserve EMS resources that way. So that guidance has been out there. And as was mentioned earlier, our EMS responses statewide are about, the last time I checked, about 26% less than they were same time period last year. And then from month to month, it's the same thing, a 33% decrease since from before COVID to now. And so the EMS system is not being stressed at the moment, though. Like I said, we have a couple mechanisms in place to help when or if that occurs. And then the third thing that we're working on as a planning group is when we hit that surge and a particular area or areas are stressed, how do we respond as a state? And so those conversations are occurring. And again, it's kind of like an incremental process. We have this part figured out, we have the next part figured out, and we're working towards putting the final touches on that process. And I don't know, Tim or Dan Schaefer's been intimately involved in the process. Dan Donlin, I don't know if any of you want to provide any additional information or comment on our planning processes.
Well, I'll just quickly jump in and then see if there's any additional comments and keep it really short. The last few days, there have been meetings relative to the new plan that's emerged from the governor's office. And so up until this point, we've been operating under the base plans that have a tier 1, 2A, 2B, and 3. Just very quickly, 1, clear blue skies. 2A, hospitals and long-term care surgery within their existing resources in terms of staff. 2B, needing additional staff from the outside, equipment, and other resources. And it's really felt that that would be the end of it for our state, that we wouldn't get to the minimum care facilities, which is 3. And that is not an alternative hospital. It is envisioned as just what it says, a minimum care facility, meaning hydration, nutrition, hygiene, maybe some ventilatory support. So in a nutshell, what's changed now, if you've been following the base plan, is that with the governor's new plan, it's all of that for the most part. Long-term care and hospitals now have a single plan, but there's also now the addition of 4 regional coordinators that would assist in the inter-region transfer of residents and patients. So there may be some more granular level in terms of in the past, when we've had major evacuations, for example, of say Fargo in 2009, or even the burn, the fire that we had in Fargo recently. Those plans followed a statewide approach, and now it's going to be more regional. More to come on that. So that's just a very high level. And let me see if Dan Schaefer, Dan Donlin have anything to add.
Yeah, you bet. Thanks, Tim. As far as the planning group and what that particular plan looks like, it's well, it's a little complex, but I think as of and I'm sorry my days have ran into each other. I think it was yesterday when we had that meeting, and that plan was kind of finalized to the point where people felt comfortable, and I believe it's been pushed up now as looking for approval, correct? And the idea, and I don't want anybody to feel like they're kept in the dark, because that's not the point at all. It's just that we needed to put a plan together that was applicable to the entire state. And of course, it needs to be able to be regionalized and or community-based, depending on the whole circumstance. And I think that the plan is not complicated, but somewhat complex, but it's almost ready to go out. But the point is, you wouldn't release it. You wouldn't have to release it unless we need it. And that's kind of where that's at. And I think that sharing that plan would be somewhat premature at this point, only because we got to make sure that it's clear and solid and approved. And I think that Mr. Wiedrich and Mr. Price would agree with that point. So.
And this is Dan Donlin, and from the PSAP perspective, we're a collaborative partner in that regard. And we have a PSAP conference call with, like I said, up to the 21, 22 PSAPs, whoever can join weekly. So we have our own PSAP call where we're trying to plan for these things, but we also are joining in with that EMS contingency planning group that is working on that plan. So we're a collaborative partner. that are trying to ensure that we're all working together for if and when things elevate to that surge.
And Kelly, this is Tim from the Hospital Association. And, again, we have spent some time talking about, the different tiers, and Tim's done a good job in educating my hospitals on how that's all going to work. So we typically try to do that during our weekly call. I know there's been some changes to it in terms of trying to incorporate, I think like Tim said, the long-term care group into it. And I know they're meeting, and I know we're going to be meeting tomorrow with the big 6 hospitals to kind of talk a little bit about some of the changes. So I would think that would probably be, if we can come to, I think, whatever, an understanding or agreement, I think that plan will probably be done shortly, I guess. Did I state that right, Tim, in terms of trying to make the final touches on that? I know there's been some modifications, and I know both long-term care and the hospitals are talking about it this week, but after that, I'm not saying it's going to be final, but I would think it would be pretty close.
No, I would agree with all that.
All right, very good answer to a pretty complex question. Thank you for being very detailed in that. Dr. Sather, looks like you're up. This person would like to know your opinion on point-of-care testing for the virus.
So I was wondering what the exact context of that question was. So so there's point-of-care testing that's now being released, and I'm not sure if they're asking about carrying it on the ambulance or not. I'm assuming it must be part of the question. And there's really only 3 reasons I would see really for testing that testing even does. And one you would not even consider for an ambulance service for going out on a call, and that's the public health monitoring component, which is really the biggest reason that we're doing testing around the state. So that's not something an ambulance service is probably going to do, is run out to a team and do a single point of care test. The state might be looking at that at some level, and maybe would engage. But so for an ambulance service to want to get a point of care test, that wouldn't be a reason. The other reason to do testing is to guide treatment. And from the EMS, first of all, in general, there's not significant benefit in guiding treatment in testing for COVID patients.
I think we just lost Dr. Sather. He froze up there. If he gets back on, we'll go back to the, allow him to finish his question. We did get a couple of questions online while we've been sitting here. One question was, and I think we can probably refer this one to Dan Schaefer or maybe Chris Price. We're having a hard time getting some supplies and PPE. What conditions would be allowable for expired supplies or PPE for use on the ambulances? Is there a procedure we need to follow for that?
So this is Tim. It's going to depend on what it is that we're talking about. I know that we're doing major distribution of N95 masks and other PPE from the state medical cache. And normally product has supply expiration dates, and there's going to be variability depending on what it is that we're talking about. So for example, while much of the nation has been suffering from lack of PPE, North Dakota had a significant supply, and I'll just pick on N95 masks. We had 1.6 million N95 masks at the outset of this situation because of medical cache. The CDC did a test by pulling 10 samples from around the country to test the viability of the PPE, and was able to demonstrate the effectiveness despite the fact that what they tested ranged from 2003 manufacture date to present. Most of what we have is in the 2007-2008 modality, and so it was proven to be effective, and so is being utilized. The fact of the matter is that it's going to have an influence depending on what the specific product is that we're talking about, whether it can or can't be utilized. But generally, product can be safely utilized depending on the outside packaging and whether it's intact. And for things like PPE, has the rubber dried out or the elastic become brittle, And some of the product that we're shipping, I'm sure that has, in fact, I know it's happened for a small quantity of the product, but that doesn't mean that it's not viable. On the other hand, there can be degradation of the potency of medication. So it's a different answer depending on what it is that we're talking about.
Very good.
Kelly,
Dan,
I'm back on, and if you want me to finish that at some point, let me know.
Yeah, will do. Dan, did you want to jump on that at all? Dan Schaefer with the SARS fight? Okay, very good. Then we did get Dr. Sather back. So Dr. Sather, do you want to go ahead and finish up your?
I can go ahead and finish. I was sitting here in my dark office. Power went out, so my computer quit. Sorry about that. So the one reason for doing a test, point of care test at the scene really is of no benefit, because symptomatic care, if you're going to treat their symptomology, if they need airway support, you're going to support their airway, etc. I mentioned the public health tracing isn't a reason for an ambulance to carry an individual test. The third reason that someone might want to consider a test is, does it guide PPE? And I had up on my desktop, I actually looked up, so I don't have it in front of me now, but I looked up one of the point of care tests. And if you go read the bottom statement after the little, they specifically say that this test is only available because of the emergency declaration and has not been cleared by the FDA or approved by the FDA. And once the emergency declaration goes away, the test goes away because it's not been through process. And I think it's an important thing to point out is some of these tests have been developed very quickly, and we don't have the normal information we have about testing. For example, the glucose monitor most ambulance services carry has been validated. There's lots of information, and we know how accurate they are. We can trust the readings. So when you talk about some of these tests, some of the reading I've done on some preliminary verification of some of these tests, the negative, false negative tests, meaning someone might test negative when they're actually positive for disease, can be as high as 25%. So in no way do you want to use this test to decide I don't need the level of PPE I would normally have. So if your policy is to go out and use a certain level of PPE all the time during this pandemic, or upgrade to a higher level of PPE when there's respiratory symptoms, that should not change based on some of these point of care testing at this point in time, because we don't know a lot of information about the tests. So that's really the only three reasons I could come up with that someone might even ask this question, unless it was something outside of specific use in an ambulance.
Okay, very good. I hope you get your lights back soon, Dr. Sather. So this next question is going to be to either Chris or Tim. Will the second round of the REMS grant proceed as expected, or will the program change because of the public health emergency?
No, we will work on that as if there was nothing else going on. We've actually begun some preliminary work on it, and we anticipate that being as if this event we're involved in never happened.
There you go, straight from the horse's mouth. So the one thing that we haven't really talked about here, but I know North Dakota EMS Association has been in some conversations with the Sheriff's Association and the Police Chiefs Association, and the fire chiefs were also invited to these meetings as well. And this was spearheaded through law enforcement, through the chiefs and the sheriff's associations, where they wanted to send a letter off to Governor Burgum and trickle through the system to obtain not only home addresses of suspected COVID patients, but to go further in as so much as getting names and date of births of actual COVID positive patients, so that responders of all EMS, law enforcement, fire could be given that information. There's many different facets of that going on. The first talks with the director, Mylan Tufte, has been done in conjunction with the AG's office. Initially, we were asking for suspected COVID versus and COVID positives, but I think at this point we've stipulated to just COVID positives, and that's still going through the process. We had a lengthy conversation with health department the other day. I'm not sure where that's laying, but if a point of interest, if you would like to read the letter that was sent, it is posted on our website. And the website is ndemsa.org. Dan, I put that out there. If you'd like to expand beyond that, Dan Donlin.
Yeah, Kelly, you covered it pretty well. There was a long conversation that the Department of Health had just this week, Monday, I believe, with Donnell Presky Association of Counties, along with the North Dakota Chiefs Association, North Dakota Sheriff's Association. A lot of talk back and forth. It was probably about an hour-long phone call. As Kelly said, there are many different levels of making that happen. It could be very complicated, or it could be quite simple, depending who you talk to. So the conversation was had, and just to clarify right now, what is being received are addresses for positive COVID, close contacts, and household members. Those are the addresses that are being received. If we go name and date of birth, all that could stay the same, or we may not continue to utilize the close contacts, simply because we're getting a lot of misaddressing, a lot of PO boxes that we can't get addresses on, and that type of stuff. With the contact information, people, it's not as accurate and reliable. So there was talk about trading that off and just using the addresses and names and DOB of COVID positives. Then the discussion was the mechanism that would happen. With 21 different dispatch centers, there's umpteen different RMS or records management systems where the name and DOB would be put in. It's not like it can be entered like an address into CAD. It would have to come out of an RMS. That creates a bunch of issues in and of itself. If Williston registers one of their residents' name and DOB, but the person drives to Bismarck, and Williston's the only PSAP with the name, well, it doesn't do any good. So there's been discussion of putting those names and dates of birth in what is called in the law enforcement world quiz, CWIS, and that would just be, as an example, that's where if you ran a name and date of birth, it could come up as a hit for if somebody had a protection order against them or had a warrant or things like that. Well, all that would happen is utilizing the same platform, but just having it as a COVID positive. Now, law enforcement has access through their CAD to run that, or they would typically run that request through their dispatch center to check the name and date of birth. The caveat with all this that we have not mentioned, even with the addresses out there, but especially and same thing with the name and date of birth, any illegal release of this confidential information, which means outside of that non-disclosure agreement that every PSAP signed, that was also sent to every 911 coordinator in the state to get out to every agency, fire, EMS, and law, with the understanding any release of that information, address, location, individuals, anything in that regard, outside of that non-disclosure agreement on an as-needed basis to who is responding is a Class C felony. And that's very important. This is highly confidential information. So Department of Health is discussing now and looking at potentially the name and DOB, but the real issue is the confidentiality, that it gets to the least amount of eyes, if you will, seen. And again, through quiz, it's only if a name and date of birth is run, and it has to be run for legitimate purpose. Otherwise, it's a C felony. So that's kind of where it's at. It's, Kelly, like you said, it could be simple in that regard. However, I'm not going to say it's simple for Jenny Moeller's regard, because all that information is coming from DOH to her, and then, you know, whatnot. If quiz doesn't work, because that was one of the issues with Department of Health legal, and we were hoping to provide them some more information. It's audited. We can audit that. We can see who's running names, all that type of stuff. So it really is very secure. But the other avenue, which would be way more difficult though, is just utilizing the spreadsheet that would come from the Department of Health with the name and DOB and the addresses, and then having to have dispatch centers cross-check that spreadsheet for a name and a date of birth of over 500 and some people, right? 400 and some, whatever it is, to see if that person, at the request of EMS, fire, or law, is a COVID positive. So it's very convoluted, and they're looking at that process now. So bottom line, decision has not been made yet.
Correct. Thank you, Dan. One of the other reasons why we wanted to pursue name and date of birth as opposed to what's currently being done with local address is how many times in an ambulance do we always go to the address to pick up a patient? We do things in Walmart. We do things in parking lots. So the address thing wouldn't do us any good. So it was just one more avenue to help protect first responders out there. And so I appreciate, Dan, that you given some more insight on that. So with that, I'm not seeing any other questions on the chat box, nor am I seeing any other questions being fed to me through NDEMSA. And all the questions that I have on my papers in front of me have been addressed. So with that, I'm going to call this town hall closed, and I want to thank the panelists tonight for being on here. There's a couple of things I want to say. Metro videos are now been uploaded on NDEMSA website. That's ndemsa.org. Dan Schaefer will be available for autographs. Again, I'll say that you go to ndemsa.org, click on the COVID-19 updates. You'll see every update that the Department of Health has provided us. You'll see the letter that we sent off to the governor regarding names and date of birth. We do have a couple questions just popped in, so let us do those questions. One is, are ambulance services regulated by OSHA? Who can answer that one for them?
I'll take a stab, and then anybody else, Dan, Tim can chime in. So in general, OSHA regulates ambulance services that are not governmental. So if you are a private for-profit or nonprofit, then you would fall under the OSHA standards.
Very good. Does anybody else want to chime in on that? I think that clarifies it.
Yep, even though we're not an OSHA state per se, absolutely correct, and we have to follow the guidance of OSHA. So yeah, Chris is spot on.
Very good. And with that, again, thank you to our panelists, and I hope everybody enjoyed tonight's town hall. I know there's been a lot of good information put out on the chats, so I appreciate that. And with that, we'll call it a night. Thank you, everybody.